All right, now we've settled out. Thank you for joining us this evening and welcome to the first instructional seminar of the American Head and Neck Society Virtual Educational Series. Thank you to our AHNS leadership and international meeting organizers for hosting this and recognizing the importance of sharing scientific progress despite the pandemic and inability to be together in Chicago. This is a special time for the field of head and neck. A decade ago, after HPV-related oropharynx cancer was identified to be a unique clinical entity with prognostic benefit, the possibility of therapeutic de-intensification for a subset of HPV-positive patients was raised. In his AHNS presidential address in 2010, Drew Ridge recognized the reality of our multidisciplinary stakeholders and the diminutive position of surgeons in this landscape. He notably said that we, surgeons, show pictures and they, radiation oncologists and medical oncologists, show curves, as well as astutely pointing out that there is no we or they. I was completing training at the time, but it was abundantly clear that de-intensification trials would require the intellectual input, clinical acumen, and coordination of the entire multidisciplinary team. Yet surgeons were not participating or performing trials. In effect, ringing the alarm bell, Drew said, many radiation and medical oncologists do not believe that modern surgery holds promise in the treatment of oropharynx cancer. 10 years later, it's exciting to see the initial therapeutic de-intensification trials come to fruition due to the collaborative efforts of head and neck surgical oncologists, radiation oncologists, and medical oncologists, our societies, cooperative groups, and patients across the United States. Findings from 2 studies exploring 2 distinct strategies of de-intensification will be presented today. The first, E3311, was a cooperative group trial led by Bob Ferris, which examined whether surgery can be used in the armamentarium to de-intensify adjuvant therapy. Notably, this represents a remarkable accomplishment of orchestrating a trial predicated upon surgeon participation in all aspects of clinical trials after an epoch of no participation, which the head and neck field should be proud of and should build upon going forward. The second, NRG HN002, explored the reduction of radiotherapy volumes and dose and the role of cisplatin. Soo Yam was forward-thinking, and the winning arm is being used for subsequent de-intensification trial to keep the forward momentum going. Bob Ferris will be our first panelist tonight. He's Hillman Professor and Director of the University of Pittsburgh Hillman Cancer Center, Professor of Otolaryngology, Immunology, and Radiation Oncology. Soo Yam is our second panelist. She's Vice Chair of Strategic Advisory, the Jacobs Distinguished Professor of Head and Neck Radiation Oncology, and Director of Head and Neck and Cutaneous and Thoracic Radiation Oncology at the University of California, San Francisco. Bob and Sue will undoubtedly both show us some curves, not pictures. Please send questions in the Q&A box, and we will have time for discussion at the end. We'll have 25 minutes of discussion at the end. And then tomorrow, the American Head and Neck Society will send you a link to claim your CME. So you can do that, and the next slide is disclosures. Bob, you're up.
Thank you, Dr. Fakhri. Welcome to everybody. It's a pleasure and an honor to participate in this, and hopefully you can see my slides. For those on mute, the tell-all head nod is very helpful. Welcome to Dr. Yam. As a group of surgeons, we're delighted to have a radiation oncologist in our midst, and we look forward to a good discussion. So I'm pleased to present the role of transoral surgery, as Dr. Fakhri indicated and introduced. The results of recently completed and presented clinical trial, the ECOG 3311, and discuss how it may affect clinical practice. These are my disclosures, and of course, you know, our departmental motto coined by Gene Myers, we like to heal with steel in Pittsburgh. So by way of background, it's been over 10 years, coming up, honestly, 11 years. Hard to believe that the FDA cleared the transoral robot. That was the intuitive device. I think, as you saw from my conflicts, I don't have any with the robotic device companies, but this was the device that was approved. And for T1 and T2 tumors, benign and malignant tumors of the head and neck. And so how did we use it? How should we use it? Well, I want to remind everybody that the current standard of care for adjuvant therapy for so-called high-risk head and neck cancer was defined by 2 prospective randomized trials shown here, the EORTC in Europe, and the American trial, the RTOG 9501. And this was reviewed by Jacques Bernier and Jay Cooper in a meta-analysis where they showed that high-risk features of positive margins and extracapsular spread or extranodal extension were the high-risk features to use to add chemotherapy to postoperative radiation. And I want us to remember that although this has made its way into standard practice, this was from an unplanned retrospective subset analysis. And so I think from the standpoint of prospective validation on the one hand, and that most of these trials were oral cavity carcinoma, primarily HPV negative, then in the setting of a new disease, HPV positive cancer with a different prognostic outcome, that we need to really reevaluate pathologic features for what adjuvant therapy needs to be delivered. And then we confirmed some data in Pittsburgh. Our previous fellow, Dr. Jesse Maxwell, who's now down in Georgetown, confirming data out of WashU from Bruce Hoey and James Lewis, showed that extranodal extension or extracapsular spread does not have the same negative prognostic impact for HPV positive head and neck cancers as it does for HPV negative head and neck cancers. And this is data from Leon Barnes, the pathologist in Pittsburgh, who scored these for extranodal extension far before anybody knew there was HPV status. So this is really a controlled experiment where the 20% survival decrement for HPV negative cancers in the setting of extranodal extension is not seen, at least in this retrospective analysis. So we really have to reevaluate selection of adjuvant therapy. And this led to the design of a clinical trial using a transoral robotic surgery. This was ECOG 3311, designed in close collaboration with committee chair, Dr. Barbara Burtness, a number of others, as you see, are co-authors here. And this was an attempt to use upfront transoral robotic surgical resection, although any resection technique was permitted, to permit lower dose postoperative radiation therapy in resectable HPV positive or P16 positive as the surrogate biomarker oropharynx cancer. And so the background, just to give you, since I'm the first speaker, is that 15,000 new cases of HPV positive oropharynx cancer are diagnosed annually. This is now the most common newly diagnosed HPV positive cancer in North America. And definitive chemoradiation is highly curative for HPV positive oropharynx cancer, but based on data from Mitch McTay and a number of others, leads to late toxicity, and these patients populate our new survivorship clinics that have cropped up in the past 5 years or so, since postoperative chemoradiation can also lead to late toxicities. And so, as I mentioned, there is a FDA clearance of the transoral surgical robot, and investigators, surgeons around the country began using it since 2009. And yet in our multidisciplinary teams, patients still were getting standard dose radiation and or chemotherapy. And we really wanted to ask the question, was this necessary? And so we conducted E3311 to study whether upfront transoral resection could permit reduced postoperative radiation therapy and maintaining high cure rates, with the hope for reducing late functional impairment in patients with intermediate risk resected disease. And so the enrollment population was P16 positive, newly diagnosed oropharynx cancer, amenable to transoral surgical resection, and as we later modified, candidates for de-intensification. So we were not trying to resect the biggest, highest volume disease. All patients underwent transoral surgery followed by risk-adjusted postoperative therapy, and this was determined by pathological parameters, extranodal extension or ENE, margin status, and number of positive metastatic nodes. There were 4 arms, but I would really think of it as 3 arms of the trial. Arm A was the low-risk arm. This is for patients who had negative margins, which we defined as greater than 3 millimeters, no more than a single positive metastatic node, and no extranodal extension, and these patients got observed. On the higher risk arm D, these patients had a positive margin. There was only about 3% of these on the trial, by the way. greater than 1 millimeter of extranodal extension, so-called gross extranodal extension, or 5 or more metastatic lymph nodes. And then arms B and C were really a single group of patients who had close margins, less than 3 millimeters, up to 4 metastatic nodes, and microscopic, or up to 1 millimeter of extranodal extension. In neck dissections from HPV positive cancer, there's about a 60% rate of E&E, and half of them are less than 1 millimeter, and half are greater than 1 millimeter. And so in this group of intermediate risk factors, they were randomized to arm B at 50 gray of radiation with no chemo, or arm C, which was 60 gray, standard dose, again with no chemo. We stratified by smoking history based on data from Ang and Gillison that 10-pack here appeared to stratify patients. There's a bit of controversy there based on Brian O'Sullivan's data. And in collaboration with Kate Hutchison and Jan Lewin, two wonderful intelligent speech and swallowing therapists at MD Anderson, we have over 1,000 modified barium swallows on patients on this trial, and very detailed patient-reported outcomes using FACT-HN, MDADI, and other quality of life surveys. Here's the schema. Everybody with AJCC7, stage 3 and 4 disease, got upfront surgery, and then baseline functional and quality of life assessments with a modified barium swallow and their patient-reported outcome surveys. After transoral resection, the low-risk group got observation, as I said. The high-risk group got standard 66 gray of radiation plus weekly cisplatin at 40 milligrams per meter squared. And the intermediate risk pathologic group, as I mentioned, got randomized to 50 versus 60 gray, 50 being the experimental arm, and neither having chemotherapy. And then we estimated that you should have at least 85% 2-year progression-free survival as our primary endpoint. We had a second primary endpoint, which was simply feasibility of prospective multi-institutional study of transoral surgery, since a prospective surgical trial had not really been mounted through the NCI funded cooperative groups, and this was done at over 60 centers. So we evaluated the ability to accrue, surgical quality in terms of margin rate and bleeding. The grade 3 and 4 bleeding rate was about 5%, and the margins were 3 to 4%, and whether we were distributing appropriately into the adjuvant arms. And then, as I mentioned, the 2-year progression-free survival of either arm, 50 or 60 gray, hoping for at least 85%. And the statistics were based on the lower edge of the confidence intervals not touching 85%. So we considered transoral surgery plus low-dose radiation worthy of further study if the upper limit of the exact 90% binomial confidence interval exceeded 85% in either arm, B and C. We needed 180 patients randomized, and we ended up with over 200 randomized to these two arms. Initially, surgeons were selecting patients with a little bit higher risk. And so we had, through the American Head and Neck Society, we had investigator meetings coordinated and really advised patients to look for, advised surgeons to look for patients who were candidates for de-intensification. This led to an initial accrual of 377 based on a pre-specified target with the NCI to be increased up to 515. And eventually we accrued 519 patients to this trial. We had interim analyses, stopping rules, and none of them were triggered as part of this trial. Arm A, as I mentioned, was observation. And if there was more than a single recurrence in arm A, that arm would go away, and that was never triggered. With very close collaboration with Dr. Chris Holsinger at Stanford, we designed a credentialing process for the surgeons because we wanted high quality surgery, and we wanted the experimental question to be around the dose of radiation, not having surgeons learning on the trial. So we had about 120 applications, eventually credentialed 87 surgeons from about 60 sites across the US. I mentioned the pathologically assessed risk, and here is the treatment arm distribution for the 353 eligible and treated patients. 11% were observed and got no further therapy. 58% underwent randomization, about 102 at 50 gray, 104 at 60 gray, and the standard dose chemoradiation arm was 31%. The way people became high risk and got assigned to arm D was 76% due to gross extranodal extension, and then a lesser extent due to multiple positive nodes. Overall, the positive margin rate was about 4% and very unlikely to occur. Now, there were a series of patients that we would like to include in the ultimate manuscript that were deemed ineligible, many of them due to some scans or labs that were not done due to protocol. And there was a bit of a learning curve for surgeons who were somewhat new to clinical trials. If the protocol said that you couldn't enroll a patient who had a CT scan inside of a 28-day window and the CT scan was 29 days old, they were deemed ineligible. But we hope to use that real-world data for a larger number of patients. Here's the consort diagram showing the enrollment of 519 patients and how they eventually were distributed into the arms to be the 353 who were eventually deemed eligible and treated. I should indicate that the entire cohort of patients who underwent surgery mirrored the treatment arm distribution, so there's no discordance between the initial group and those who I'm reporting today. Here are some of the reasons for patients that were deemed ineligible. And so, as I mentioned, the 2-year progression-free survival rate was defined as the proportion of patients alive and progression-free at 24 months. The data I'm reporting today has a median follow-up of about 30 months. Here are some of the other reasons patients were deemed ineligible or lost to follow-up. So here are the results for the 4 different arms. The observation, low-risk arm, almost 94% 2-year progression-free survival. In terms of arms B and C, the 50 gray arm had a 95% 2-year PFS. The 60 gray arm had a 95.9% 2-year PFS. The same number of recurrences in each arm, 50 versus 60 gray, although distant in the 60 gray arm and distributed local regional failure versus distant in the 50 gray arm. And then arm D, the high-risk group, who had extensive extranodal extension or 5 or more metastatic nodes, a 90.5% 2-year PFS. 2 treatment-related deaths, 1 in the surgical arm due to lack of ligation of the feeding arterial vessels, and 1 in the chemoradiation arm. We conclude that transoral surgery with low-dose radiation, 50 gray, without chemotherapy, is worthy of further study, because as you can see from the 90% confidence intervals, these always exceeded 85%. In fact, if you go back and double the rates of recurrence here with a 3 and a 4-year follow-up, you still maintain 90% confidence intervals above 85%. Here are the Kaplan-Meier progression-free survival 2-year PFS estimates, and you can see these curves are relatively overlapping. If you look at later time points, however, the high-risk arm D group that did get chemo and radiation after TORS begins to separate a bit. I should mention, by the way, 90% of the patients got TORS and about 10% were treated with transoral laser. And so in conclusion, transoral resection of P16 positive oropharynx cancer is safe, results in very good oncologic outcome, and appears to be a promising deintensification approach. For patients with low-risk disease, 2-year PFS is favorable without any postoperative therapy. For those with uninvolved surgical margins, less than 5 involved nodes, and microscopic extranodal extension, about half of the neck dissections, reduced dose, 50 gray of postoperative radiation therapy without chemotherapy appears sufficient. This allowed deintensification of 70% of the patients on this trial. So transoral surgery plus 50 gray should be compared to an optimal non-surgical therapy in a phase 3 trial for patients with intermediate risk. I'd like to thank all of the institutions and investigators who helped contribute to this trial and accrue to it. Thank you.
So I wasn't sure if Carol was going to come on and prompt me. Thanks, Bob. That was great. And I'm going to go ahead and share my screen now, if you're released. My talk's going to be a little bit different in that I tried to think about what would be helpful. And so it's going to be a little more, I would say, conceptual, although we will talk about HN002. This is about what I see as evolutions in radiotherapy volumes and dose. And I want to thank Carol Fackery in particular, but as well Bob and the AHNS for inviting me here and allowing me to take place in the first webinar. It's really an honor. I do have a couple disclosures of payments to my institutions for research, my institution for research, and then to me for some royalties and honoraria for my work at the Red Journal. So the learning objectives are today to appreciate some of the complexity in de-intensifying radiation therapy for these patients, acknowledge the limitations of prescribed dose as a metric of de-intensification, and to understand the differences in rationale for the current clinical trials. This is a little bit historical. So this is Gilbert Fletcher, and for those of you who don't know, he was foundational for head and neck cancer at the MD Anderson. And radiation for a long time was considered, and still is, the curative linchpin for non-operated gross disease. Of course, that's, you know, evolving all the time, but still remains a fundamental concept. And back then, it's an interesting historical note that really the dose in head and neck was very binary. For what was called obvious disease, 70 Gray was thought to be sort of the benchmark. And for what was non-obvious or subclinical disease, 50 Gray was the benchmark. And as Fletcher's textbook, which is historic and remarkable to read even to this day, said, it really wasn't until the 1960s that we had specific dose schedules for various tumors, which were based on empiric experience. And here are some of the papers from Dr. Fletcher's work in this area. I show this to you because I think it's so striking that, as you can see here in this paper on the tonsillar fossa, what he reported was that all the T1 tumors were controlled with approximately 65 Gray. We're just going to call rad centigrade for now, so 65 Gray. For T2 tumors, 70 Gray was required. For T3 and T4 tumors, he recommended 75 Gray, and in the base of tongue, they saw failures even up as high as 80 Gray. And for lymph nodes, the control rate was very high. Remember, this is with radiation therapy alone in sort of the, you know, palpation pre-CT era. The control for N1 lymph nodes was over 90%, and the dose response showed that 65 Gray produced 90% control. So I think that's a really helpful historical perspective. And, you know, the thing is, when we talk about dose, even when we just talked about dose just now, those prescriptions are written in terms of the tumor dose. And the tumor dose is what we call the gross disease dose, or the GTV dose, to either primary disease or lymph node disease that is gross and evident. But in the modern era, this is a really complicated thing. In the modern era, as many of you may be aware, if you've spent time talking to your radiation oncologist, we use computer planning. And so instead of delivering radiation through cut Saraband blocks, which is just sort of straight through and through as a giant field like you see in the bottom panel, we now give intensity modulated radiation therapy, which involves leaves that open and close for a given amount of time. And it's the amount of time that determines the intensity of the pixel that's delivered at what we call these dose control points. And all these dose control points combine to make this complex three-dimensional shape. And furthermore, within the head and neck region, we prescribe at multiple dose levels. So high dose, high risk, intermediate risk, low risk, as well as gross disease. But that's all generically described by this one prescription dose to the gross disease. And it's also important to note that that dose to the gross disease covers 95% of a planning volume. The planning volume is the gross disease plus a margin, which can range anywhere as high as 1.5 centimeters or 7 millimeters. But the true dose to the actual gross tumor within that planning volume can actually be higher than what that prescription dose showed. And the last thing to talk about is that, you know, within the cooperative groups, as you know, many of you have realized, we have to go with a one-size-fits-all strategy to make these trials coherent. And so for R2G 1016, for example, 70 Gray is prescribed with cisplatin. And it's important to remember that 20% of the patients in that trial had T1 disease. You know, it's really a question whether they needed 70 Gray, but they were within that trial. So this is NRG HN002. As many of you know, we completed this full accrual to this trial with 306 eligible and enrolled patients at the end of it. And many people think about this as the 60 gray trial. It was indeed 60 gray in conventional fractionation in combination with weekly cisplatin, very similar to what Dr. Ferris described, compared against an accelerated radiation therapy arm, which was 60 gray, but accelerated to finish within 5 weeks. And in this randomization, it's important to remember that while we talk about 60 gray, right there, you already see that 60 gray is being delivered 2 ways. And furthermore, 60 gray is a really simple way to talk about this treatment plan. This is, you know, really when you step back and sort of appreciate the level of technology we're at, this is a simultaneous integrated IMRT plan, so intensity modulated. And you can see from this cartoon schema that we used to help people when they were designing volumes for the trial, while the gross disease is indeed receiving 60 gray, we treated to 54 gray to the involved neck, and the uninvolved areas to the elective regions were 48 gray. I'm just going to point out that that is 1.6 gray per fraction over 30 fractions, because this is simultaneous integrated, meaning all of this went in 30 fractions at the same time. And for those of you who know what that means, there is a lot of concern in the radiation community about low doses per fraction, which we're going to talk about in a second, why that's important here. It should be noted that HN002 was probably a little bit on the higher risk side than some of the recently publicized and well-known surgical deintensification trials. So Orator, which some of you have heard about, and ECOG 3311, as Dr. Ferris just presented, were sort of similar in the T1, T2, N1, N2B, or N0, N2B range. In HN002, I'll just point out that we had, you know, obviously no requirement for surgical eligibility. We excluded up to T2 and 0, but included up to T3 and 2B. And patients on HN002 were allowed to have minimal E&E on imaging. So the 2-year PFS for the 60 gray with chemotherapy was 90.5%. And for the accelerated radiation therapy alone was 87.6%. This has been presented at ASTRO, and it's now known that that second arm of accelerated radiation therapy did not meet the confidence interval to go forward in another trial. And then the overall survival was 97% for both arms. I think what, you know, when we start to get into the specifics, this is where it gets very interesting. We did a cumulative analysis of local regional failure. And as you can see, the local regional failure was higher in those patients who did not receive chemotherapy. While this has not really been analyzed in any depth, and really can't be because of the sample size, there is a suggestion, which I think, you know, will be evident when the final publication comes out, that this probably occurred in the bulkier tumors, and so essentially T3 tumors that were treated without chemo. But that difference was, or that issue was not evident in the chemotherapy arm. So again, you know, really fascinating that even in the deintensification HPV population, we're seeing some reconfirmation of those original principles by Fletcher about size. Distant metastasis rate was low in both arms, which is reassuring. And I will just note that there was no evident effect of concurrent cisplatin on prevention of distant metastases, again, at very low numbers here. So, you know, just to go back to the Fletcher concepts again, it's interesting from his textbook that he stated that for lymphoepithelioma, which is another virally related tumor of the nasopharynx, nasopharyngeal carcinoma, only a single local failure was observed in his series above 62.5 gray and 30 fractions. So, you know, it's just, it's an interesting thing that, you know, everything old becomes new again. And again, just re-emphasizing the point that HN002 does have some hints, although maybe nothing we can confirm with statistics, but some hints that there may be some relationship between the success of 60 gray and the size, based on the size of the tumor, but this appeared to be obviated by chemotherapy. Obviously, that was not something that Fletcher analyzed because it wasn't, we didn't do concurrent chemotherapy then. It's also, I just really want to talk about this a lot because I think the dose to subclinical, dose to subclinical elective disease in HN002 is really important. I probably, to be honest with you, did not realize how important it was at the time. Going back to some of the history of this, as Fletcher stated, 50 Gray controls subclinical disease in over 90% of head and neck cases. And the slope of this is very flat and shallow, meaning as you go higher, you don't really get a corresponding increase in efficacy. So 50 Gray is really sort of the threshold of efficacy. And as I stated earlier, there are a lot of concerns in the modern era about a low dose per fraction. And remember, we gave 1.6 Gray per fraction in HN002. And these concerns about this low dose per fraction to these elective regions of the neck led to movements during the IMRT era to raise that dose up so that the dose per fraction would be higher. But there really isn't clear data to support that. And it may even be that dose per fraction is less important for subclinical disease. Furthermore, many of our patients do get chemotherapy. So it's questionable, again, whether that is relevant. And the final thing to note is that historically, the data for elective neck has addressed the entirety of the neck. But these days, of course, we recognize that there is risk at different levels and high interest in the radiation community about tailoring dose to different parts of the neck. So in the Fletcher era, what was 50 Gray? 50 Gray looks like this. And you can see here that the doses actually decrease the further you go into depth of tissue. 50 Gray at that time was a given dose with cobalt-60, which is a superficial, very old form of radiation therapy that was common in the day. And Dr. Fletcher realized that the level 3 nodes were probably actually getting 45 Gray, as you can see from this figure here. So, the recommended dose prescriptions for this type of prescription could range from 44 and 22. Notice that's at 2 Gray per fraction, or 50.4 at 28 fractions, prescribed to some depth level. And right there, you see there's dose differences just based on how the dose per fraction is being given and what depth you're prescribing to. So 50 Gray, even 50 Gray is not simple. And as we just kind of reviewed a second ago, IMRT has led to further dose escalation. So concerns about the low dose per fraction have led to standard recommendations to increase that subclinical dose to 57 Gray. And the introduction of intermediate dose levels, like, for instance, the famous level 2, has led to this creation of an intermediate dose of 60 to 63 to treat high-risk subclinical areas. And this is very commonly how radiation is done now over 3 dose levels. But I think, just again, comparing, then to now, what does subclinical disease mean to us in this day and age? I mean, these days, our current detection of subclinical disease is very different than the obvious, non-obvious binary. And, whether dose prescriptions need to be the same to subclinical disease as it's detected in this day and age with PET scans is unclear. I think this is some very nice work from the Netherlands, and we'll talk about them a little bit more in a second. So, what directions are we going now in terms of radiation dose and radiation volume? There are multiple studies, one from the United States, from South Carolina that went as low as 36, others from the Netherlands looking at 40 Gray to the elective neck and suggesting that that is very effective. There is a Dutch study right now that randomizes between 45 Gray to the elective neck versus 35 Gray with a PET-directed boost to 60 Gray to the higher risk regions. So interesting investigations there of lowering dose to the elective neck. Volume is another area where we can reduce toxicity. And so one good example is the infield trial, which is concluded at UT Southwestern, where they are giving elective radiation to the neck to essentially the involved field first echelon. And then finally, renewed interest now in the use of sentinel lymph node detection. In the Netherlands, there is one study where they are using that, very directly to map out which areas should receive no dose. So no dose and no volume, which is probably the biggest form of de-intensification of all. I do want to point out that we did in HN002 do some creative work here with volume reduction as well. It's not common in the radiation community, or at least not that common, to offer unilateral radiation therapy. But we strongly encourage this in HN002 for tonsil-confined primaries with limited level 2 adenopathy. And those patients were able to receive unilateral radiation therapy. So again, the concept of zero dose, zero volume to the contralateral neck. So I just want to point out again, to describe this as 60 gray really misses what was really happening here on multiple dose levels and volume. So you might be wondering now, because this has been like sort of intensive radiation talk, what is the point of all of this? I tried to just get across a couple things that we can talk about more in the discussion. I feel pretty strongly that at this point in time in history, and this will be an interesting discussion to have with Dr. Ferris today, that de-intensification to a lower dose to the gross tumor, or even the choice of radiation monotherapy alone without chemotherapy, really requires a deep understanding of selection principles if we're going to use that in clinical practice. And I really feel in some ways this is very similar to surgical selection, and that we're parsing out what was one-size-fits-all data from large clinical trials and trying to determine within those subsets who's going to do well with what. And then finally, or secondly, the effectiveness of dose on HPV-related gross disease does still classically seem tied to the size of the tumor and the presence or absence of cisplatin. And so again, very similarly, we learned that from the radiation alone arm in HN002. And so similarly, just like with surgery, again, the parallel here is that, smaller tumors can get less and do better. HN002 included lower doses to the next subclinical disease. I showed you that 48 gray at the 1.6 per fraction. And, again, I think I maybe didn't realize this at the time, but in hindsight, we had to lower that because, how could we be treating the same dose of the elective neck and the gross tumor? It had to be lower in the elective neck. And so, that wasn't necessarily thought of, quite so philosophically as I do now, but in some ways that lower dose may be a more significant contribution in some ways than the lowering of gross tumor dose. And I feel that what we've shown there inadvertently is that we can do that in the regional neck safely. And finally, I just want to say, I think we will learn a lot from the upcoming, or the trial that's open for enrollment now, which is HN005. HN005 is the successor trial to HN002, and it takes a lot of its framework and backbone from HN002, but directly compares this to the 1016 classic 70 gray cisplatin approach. And my feeling is that these two trials run on the same population in the same NRG cooperative group will really tell us a complex story in the subset analyses. So here is HN005, and it's the same essential eligibility translated to AJCC 8, of course. But as you can see here, we're directly comparing the classic 1016 approach of 70 gray cisplatin to the HN002 approach of 60 gray and cisplatin, and then taking the arm from HN002, which was radiation therapy alone in an accelerated manner, but combining it with nivolumab, which is sort of the most experimental arm. And as you see here, this is built as a 2-3, where the arms out of this first phase 2 that meet the PFS and quality of life metrics can move forward into a seamless transition to phase 3. At the end of the day, if 2 arms go forward, we will have 474 patients. If 3 arms go forward, we'll have 711 patients across the 3 arms. I think it's just astonishing, again, to take a couple steps back here and realize that in 399 patients, the go, no-go decision is based on 11 PFS events per arm. And I think that's just an astonishing statistic, that really tells you something about this disease process. So I do hope everyone will, continue to support our trial. And as I said, just really viewing this as a long-term learning process for the radiation therapy community. Thank you.
You're muted, Carol.
Thank you, the basics. I did figure out how to put on a virtual background after you guys had your respective institutions. Anyways, what I was saying is if you could raise your hand if you'd like to speak up, and JJ will promote you so that we can use that functionality of Zoom. And if you are not able to raise your hand using Zoom, if you can, in the chat box, speak up, and JJ will promote you so you can speak up. So in terms of questions, I think one question that has already come up in the chat box, and that is kind of a natural between 3311 and Sue's talk is, are we ready to go to 50 gray in the adjuvant setting? And then, you know, how do you reconcile that with the Mayo study where they dropped it to 30 gray? And so considerations both from you, Bob, and from Sue.
Okay, Sue, do you want to go first? Or? Okay, I'll go first. So I don't think the Mayo group would want to intensify to 50 gray, if that's the question. Sorry, that was a joke. So I guess what I would say, and this has been a sort of few months of really thinking about it since the data came out. There's only 100 patients in the 50 gray arm. And so we would not generally say that that's a practice-changing number of patients. On the other hand, I guess I would challenge anybody to show me the clinical trial that would be needed to demonstrate to me that 60 gray is better than 50 gray. And I think the onus should be on us to show that more therapy benefits a patient as much as showing data that less therapy is safe. I think at present we've shown that less therapy is safe. Should it be confirmed in a separate data set? I think sure. You know, one of the criticisms could be, and I don't mean to point this out with the Mayo group, but they're a specialized group, highly experienced, tight, multidisciplinary team. You know, I think the advantage of an NCI cooperative group trial is it was across 60 centers. So I feel a little bit more comfortable with 50 gray because we're subject to the vagaries of, you know, many surgeons, many centers. A subset, about a quarter of our surgeons put on, you know, 10 to 15 patients or more, but, you know, the majority put on single digits. So this was by no means a trial of experienced surgeons.
So Bob, do you think in your view the next step is to reproduce it or to drop it? And I'll let you ensue.
Well,
Yeah,
I mean, I'm a surgeon, so we need a radiation oncologist to decide about the radiation dose.
I can give a little historical perspective on this. So the data I showed you from the original Fletcher description, textbooks and publications back from that era, we're really talking about unoperated elective subclinical disease areas, non-obvious as it was termed at the time. And you know, the historical basis for raising the dose to the postoperative neck, because you're probably sitting here and saying, well, she just showed all this stuff that Fletcher thought 50 was okay. And, you know, maybe 50 is really complicated, but 50 is basically okay. The reason historically for raising it to 60 gray was because there was evidence that in operated patients, the hypoxic areas of those necks was more prone to failure with that dose. And so because of that, in operated areas, we raised the dose typically to 60. But, you know, that was never confirmed in patients with HPV related disease. And it may be that, you know, those classic, you know, effects that were seen in operated necks at that time, which provide the justification for raising to 60 gray, may not be true in HPV related disease. So that's, you know, that's the kicker. And I think that's where Dr. Ferris's trial is really important, because it shows us that, you know, this may indeed be a safe pathway. And in some ways, the data that he's produced is stronger than the historical data that we have for the empiric dosing of 60 gray to the post-op neck. And I would say, you know, in my personal opinion, 60 gray to the post-op neck remains kind of the, you know, the baseline, the starting point, you know, the classic dose that we give. But you know, I do think that we're on the verge of changing, you know, our thoughts about this other disease entity. As far as, you know, whether we need a trial, I mean, I think it's real, you know, I don't know. I'm not the NCI. So, and I'm not, I'm not the NRG steering committee, but I think that, you know, with HPV related disease, non-smoking oropharynx disease, we're caught in this very difficult situation of having to run equivalence trials. And equivalence trials essentially, you know, if you really want to be sort of blunt about it, essentially mean that, you know, we design some confidence interval that, you know, this potentially, you know, lesser treatment will fall within a range that is similar to what the standard treatment is. And they require very huge patient numbers to do that. It's a difficult binary to be in. And, you know, you sort of wonder if that's efficient.
So we've also had a lot of questions about quality of life in the chat box. I think it's important to consider why we did these trials, right? Was to maintain survival and to really optimize on toxicity and quality of life, because we all know when we ask patients what's most important to them, it's cure, and then after that, quality of life is very important. And so do you want to talk a little bit about that, Bob, since there are a few questions about that?
It's a great question, and I'm sorry that I don't yet have the data. Literally over the weekend, got the clinical study report from the ECOG statistician, and she's pulling the patient-reported outcomes. We have great quality of life co-chairs who will report the PROs, and as I mentioned, Drs. Hutchison and Lewin are analyzing the modified barium swallows, and so that is in the works. We hope to include some of the QOL or MDADI data in the primary manuscript, but more detailed analyses will go in subsequent papers. I can tell you at Pittsburgh, we were the #1 accruing site, and I was the highest accruing surgeon. People do very well, but obviously that's highly anecdotal. We put, I think, 50 or 60 patients on.
You're going to give us pictures soon, Bob.
Oh yeah, pictures and curves.
Sue,
yeah, I didn't have time to, you know, present all of the intricacies, but we did have a secondary, you know, recognizing the statement you made, Carol. We had a co-primary second endpoint in HN002, which was quality of life based on the MDADI. And we did report that, and it was very good. They meant the benchmark, and it was very high. And I do think de-intensification is nice. I'll just say that.
There was a specific
of any form.
question. I guess it went away. I think you must have answered it in terms of data, Bob. JJ, I'm sorry, I just can't see if people are raising their hands, so I don't know if I need to allow for someone. Is there someone raising their hand that you want to promote, JJ?
Don't think the hand raising function is working. So if you would like to come in and discuss, please send me a note in the chat room and I'll bring you in. That's a message to our attendees.
I got a question just that folks have been asking. What we're reporting is going to be 36-month, median 36-month follow-up. So for sure, and others have shown this, that there are later recurrences, and certainly quality of life and dysphagia occur at least at 4 years. In our survivorship clinic, at 5 to 6 years. So I agree with everyone who has commented that we need to wait longer and keep reporting longer term data.
And I think that ties into one of the questions earlier about do we combine any biomarkers for HPV positive patients in terms of earlier detection, and we can find that in clinical trials. But I think if you want to answer that question, Bob, and Sue, whether or not you're going to include that in HN005.
Well, we're limited in what we can do in the cooperative groups because, a lot of the specimens we receive are very scanty FNAs. Furthermore, those type of analyses are very expensive, to be blunt. I think, unfortunately for HN002 and HN005, we will mostly be looking at clinical indicators, but I will say we have secondary analyses built in, trying to use what we can in the blood and tissue specimens that we did receive. One of the analyses we're very interested in is, of course, HPV DNA. Yeah, Bob, I don't know.
So
You guys have surgical specimens, so maybe you'll have to do this work for us.
we have saliva and serum. We wrote into the protocol 10 years ago to look at HPV DNA in the saliva and the serum, and to follow them up. Others have continued to push that field forward, and great credit goes to the new assays that are becoming available. But I think folks in the cooperative groups are awfully good at submitting specimens. We don't have them for everybody. I think it's in the 300s in terms of specimens that may be available, not all time points. And so it probably is going to be difficult to really get finely tuned follow-up with serum or saliva, but we'll certainly try. And then a slightly different biomarker question that is an area of investigation that we're interested in doing with 3311 is to preoperatively predict who's likely to go into Arm D in the hopes of reducing those who end up with 3 modalities. So we can de-intensify 70%, but can we cut Arm D in half and get them to go straight to chemoradiation, perhaps?
I will say one little twist that we have in HN005 that I thought of while you were talking was, because we have nivolumab built into that trial, we do have another sub-study on immune biomarkers, which I think will be really interesting in terms of how radiation affects those, in the blood.
So we've talked about different ways of de-intensifying, and I think in each of the trials there are different eligibility criteria for who to de-intensify. So I guess as we kind of think about where we go from here, I think that's yet another question is, who should we be de-intensifying? How do we determine it? Is it based on demographic characteristics of patients? Is it based upon their smoking and behavioral exposures? Is it based on biomarkers or a combination of that? So how do you guys think about that? And kind of as we go forward, we can keep on changing the variables in terms of treatment, but we also have to think about who we're de-intensifying. So where do we go from here?
Yeah, I mean, ideally all of it, right? Like the clinical indicators, the radiologic biomarkers, which are very important to radiation oncologists, the tissue biomarkers. I mean, ideally, genetic sequencing. I mean, ideally all of it. But we had to, design on things that were, carefully validated. And to be honest, in the NRG, we started with, that classic New England Journal of Medicine paper, which really, directed us. And one of the things in the NRG is that, we try to build on what we've done. So it's very important that we maintain a very consistent framework that we can continue to justify these studies. So that's the limitation we're working within, which is tight and small. And then the other part to talk about is that, clearly we started with what we thought was, the safest and most salvageable population. Whether de-intensification could be applied more broadly, I think is still a question that's way out there. I do think, the smoking question is very interesting because the data is a little controversial there, as I think Dr. Ferris indicated. But, at least within the NRG, that we have what we have, which is the 10-pack year cutoff. I will just mention as an aside that we really don't know the effect of chewing or marijuana or other substance abuse. It's just sort of there's a lot of unknowns still even about this very well-defined disease. I don't know if you want to add to some of this, Bob. Who else are you going to de-intensify?
Well, there's a question of what to do with the gross extranodal extension group. and whether we can use other systemic therapies, if you will, since a substantial portion of those were distant. And I think, as you pointed out in your data, and I think others have shown, that cisplatin, although we use it to intensify, is really for a local regional benefit. And we don't, although it's a systemic therapy, it sort of counterintuitively does not really work on systemic spread. And so I think the field should go toward other more different mechanisms of systemic therapy. The issue, of course, is now we're wrestling with data from ESMO on the Javelin trial that combining at least one type of immunotherapy with chemoradiation didn't benefit. And so a number of trials with the approval of PD-1 inhibitors in first and second line automatically have added it to radiation or chemoradiation. Interestingly, there was a study at ESMO also out of Europe comparing cetuximab radiation with pembrolizumab radiation, and there's really no difference. So I think trying to figure out how we can integrate other systemic therapies when folks are at high risk for distant spread, primarily that's ARMD, 5 or more metastatic nodes, gross extranodal extension, and I think that's the frontier, is distant metastasis for the HPV positive group.
Yeah, it's interesting because many people have asked me why we have that 60-grain nivolumab arm in HN005, and I'll tell you a little secret between the 200 of us who are here today, which is that arm came in and out of the trial several times, and it was actually scientists on our side and the NCI itself that, really were pretty interested in that, because, if there is an alternative to cisplatin, I do think that would be a major form of deintensification, in various settings for these patients. We just, as Bob alluded to, it's been very hard to find that,
So one alternative view is there ever a role for intensification in HPV positive patients?
I think Dr. Ferris just alluded to that. There was this Javelin trial, which he was one of the directors of. And certainly right now the IAP, I'm gonna stop talking, Bob, because you know about this stuff. You're really good at this.
He's busy.
I'm trying to answer
Maybe he's conflicted,
all questions. Somebody has to type. My fingers don't work all that. I'm used to a robot.
Yeah, so the Debio 1143 compound is very interesting to me. And that is an intensification, but it's, those are very different patients. Those are patients, as Dr. Ferris alluded to, very high risk of distant metastases and, much different outcomes than these people. I will say, an interesting puzzle, which we have not gotten our heads around, is that, and a cautionary note is that in 1016, as I showed you, there were a lot of patients in there who had pretty early stage disease. And that was an intensified trial with accelerated radiation and cisplatin. And granted, 2 cycles of 100 as opposed to 3, but still high dose cisplatin and acceleration of the radiation therapy. And interestingly enough, even in the earlier stage subsets, it appeared that cisplatin had a benefit over cetuximab. So it is something to think about.
All right, so I think we've hit the hour. It doesn't sound like anyone wanted to come up and speak. If you do, this is the last opportunity. But thank you for joining us. Thank you, Bob and Sue, for all your leadership, all your contributions, and for great talks this evening.
Great moderating and mediating.
Bye.
Thank you.
Thanks everyone for participating. Thanks for our sponsor.
You.
Thanks for the American Head and Neck Society.
Go AHNS.